Okay, welcome everybody to this IPC Partners webinar on Mpox, situation update and IPC implications that Dr. Jon Otter is going to bring to you today. Welcome to everybody. Just a little bit of housekeeping to begin with. This is a little bit different to the usual schedule of IPC Partners journal clubs that we put together. We've decided to do this one and break the schedule a little bit. Normally we're doing it every 2 weeks, but we've decided to do this one a week from the last one that we did because of the current concern and challenge and worry, I think is the right word, around Mpox. So it's something that's really topical. Of course, Mpox was declared a public health emergency in early August by the World Health Organization. And currently it's all over our media, and it's obviously a big challenge in healthcare and in particular infection prevention control. So not talking about a specific journal, more of an overview of the situation and IPC implications that John's going to guide us through. There's a Q&A box at the top of your screen. If you could use that, please, to ask any questions. And just to remind you that there's no silly questions. We're happy to take any questions, no matter what they are, and we will do our best to answer them, and we'll have plenty of time for Q&A at the end. So without further ado, I'll pass you over to Dr. Jon Otter. Thanks, John.
Thanks, Phil. Do you mean silly questions are not allowed or silly questions are allowed?
Silly questions are allowed.
Gotcha. Thought that's what you meant. No, silly questions definitely allowed. Hi everyone. I have a few silly questions of my own today because I've spent a fair bit of time trying to pull together these slides and look at the latest guidance and the evidence, but things are moving very quickly. Guidance is developing almost as we speak. I think we are anticipating some new guidance at some point next week around PPE. I'll come to that a little bit later. So first of all, by way of introduction, for those of you I haven't met before, my name's John. I'm a clinical scientist by background. I'm the director of IPC at Guy's and St Thomas's. I also do some research at Imperial College London. I have a background in bacteriology. I've done a few viruses in my time, not least SARS-CoV-2 and a little bit of COVID management. And obviously the 2022 Mpox outbreak was involved in that as well. I put down Imperial College London, Guy's and Tommy's, but just to be clear, sort of by way of disclaimer really, the thoughts I've put together today is my own synthesis of the evidence, and it's not a reflection of the guidance in those organisations. Okay, let's go back to the start then. So Mpox was first identified as a disease in monkeys in the 1950s and was consequently called monkeypox. The first human infections were reported quite a few years later in the 1970s in the Democratic Republic of the Congo in Africa. And things were relatively quiet between then and now. We have outbreaks in Africa, which we have some information on, but scanty really. And then in 2022, things really kicked off with a global outbreak of Mpox, which we'll come on to in a minute. But before that point, it was mainly outbreaks in Africa. The virus itself, the Mpox virus, is an enveloped orthopox virus in the Poxviridae family. So that's the same genus as the variola or the smallpox virus. Slightly confusing, although the symptoms are not dissimilar in some ways to chickenpox. It's from a different viral family. Chickenpox is from the herpes virus family. You can see there in the schematic a very rough overview of the key viral components, and you can see the envelope there, which is important when it comes to environmental persistence. In terms of clinical features, the incubation period can be relatively short at 5 days or much longer at 21 days. The disease, Mpox, is usually self-limiting. Most patients will recover within a few weeks. It's rare, but severe illness can occur, and there have been some Mpox-related mortality reported. Symptoms begin with a fever and some other fairly non-specific symptoms, and then 1 to 5 days after the fever, a characteristic rash appears. It often starts on the face, characterized by blisters and vesicles or scabs and ulcers. And patients are considered contagious until the scabs have fallen off and intact skin has grown below. The panels on the right, you can see these are from UKHSA, give you a sort of visual overview of the journey from the early vesicle right through to the partially removed scab. shortly after which a patient would be considered non-infectious. It's important to understand the principles of the clades involved in Mpox genomically. So the Mpox virus is split into two clades, clade 1 and clade 2. Clade 1 is largely restricted to Africa. The cases have been reported from there, barring a couple. Clade 2 was the clade that caused this global outbreak that we'll come on to talk about in a minute. So in 2022, things really took off with Mpox. Clade 2b emerged and spread globally, and you can see on the map there, which is from the CDC, the cases reported from all over the world, whereas the blue shows these cases had only been historically reported in Africa. The total count is somewhere around the 10,000 region now. There's a very close association with young men and those who are gay, bisexual, or other men who have sex with men. So that's the subpopulation that this outbreak was largely restricted to, either that group or those 1 degree of separation from them in terms of epidemiological contact. When we come up to date and start to think about the clade 1b outbreak, that is a different beast with different epidemiological characteristics. So WHO very recently declared a public health emergency of international concern because of the worry that this clade 2 Mpox outbreak, which is centered in the DRC, will spread to other countries in Africa and then outside of the continent. But it's still true that low numbers of clade 1 cases have been reported historically. So in the year 2022, around 1,000 cases were reported. In 2023, just over 3,000. And then in 2024, in just the first half of the year this year, we've seen around 15,000 suspected cases with 500 deaths attached to that. And unlike the usual clade 1 scenario, this has been associated with a broader geographical area, an even split of cases between men and women, which is in contrast to the clade 1 outbreak in relatively young men. Genomic diversity within the outbreak, so not just a single clade or subclade, and frequent involvement of sex workers. There have been 2 imported cases of clade 1b Mpox outside of Africa, one in Sweden, one in Thailand, both earlier this month. Both of these individuals had travel links to the affected regions in Africa, so it looked like they were not local transmission in those countries, but rather imported cases from Africa. No clade 1 cases have been reported in the UK yet, and UKHSA assessed the overall risk to the public to be low. I think it's probably true, though. We should prepare and possibly even expect 1 or 2 clade 1 Mpox cases with travel history to Africa to show up in this country sometime soon. I don't have a crystal ball. I don't know that that's going to be the case. I don't think there's expectation of widespread community transmission. Again, we could be surprised, but that's how it's looking at the moment. So because this is such breaking news, there's not really any published data around the latest clade 2 clusters in Africa and their epidemiological characteristics. So I've gone to medRxiv, which is a preprint publication. So this is based on non-peer-reviewed data, and it's an outbreak report for the first 250 odd suspected cases in the DRC. You can see there the even male-female gender distribution in contrast to the clade 2b outbreak, and almost a third of these cases were in sex workers. Looking in a little bit more detail around the genomics, you can see there is a diversity of clades involved, and you can see how clearly the clade 1b outbreak, which is the one that's prompted the WHO declaration, has emerged fairly recently. So case fatality rate is a measure of disease severity based on the number of cases who die. I think all of this needs to be interpreted with caution. So clade 1 case fatality rate prior to 2022 has been reported in excess of 10%. I think that's probably an overestimation of what you might describe as the true case fatality rate, because we know surveillance hasn't been great in those historic outbreaks. So there's been a lot of low-level symptomatic, asymptomatic cases that would sort of inflate your denominator for a case fatality rate calculation. and mean that the overall case fatality rate would be lower if all of the cases that you didn't know about were included. Clade 2, prior to 2022, case fatality rate of just under 4, but again, probably overestimated. I think the other factor is to think about where in the world these cases are occurring and the levels of basic healthcare that is being provided to the individuals. I suspect that if we had one of these individuals in a more developed healthcare system, they'd get better basic care and have a lower likelihood of a poor outcome. Clade 2 outbreak in 2022, we know the case fatality rate was less than 1%. And again, I think that's a feature of the improved surveillance and perhaps of the evolution of the virus itself. And then most recently, the Clade 1b outbreak that we're really here to talk about today. Based on the very early data, the case fatality rate is coming out at around 3%, but again, interpreted with caution. Going back to medRxiv, so this is some modelling data from a group at Imperial College London who did some great work modelling around COVID. They've modelled the relationship between the case fatality rate, or CFR, and age based on historic Mpox Clade 1 data. And the trend is quite interesting. There's a very much a skew to younger age groups with the case fatality rate at the lower ages ranging between 0.25 and 0.75. Whereas as the age increases, it drops right down. So there's some important learning to be had around case fatality rate and how it correlates with age. So treatment for Mpox overall is mainly supportive. So hydration, skincare, the usual sorts of things. Antiviral drugs are available and have some level of efficacy to treat patients with severe disease, particularly early in disease. Or those who are at high risk of severe disease. We are still learning around efficacy of antivirals to treat Mpox. Vaccination, so there isn't a specific Mpox vaccine, hasn't been developed yet, but the smallpox vaccine that's been used for many years can be used to support control of outbreaks. People vaccinated against smallpox early in their life may experience milder disease if they come in contact with Mpox. And it's probably true that on a sort of community level, that the wane in smallpox on a global level, right down to extinction, has probably resulted in the wax in Mpox because community levels of immunity against smallpox coming down would mean that community resilience against Mpox will also come down, and the population becomes more susceptible to Mpox. Some people right now are eligible for Mpox vaccination in this country. So some healthcare workers, some members of the community, and some close contacts will be eligible under current guidance. Specific Mpox vaccines are being developed, so we're trying to leverage the brilliant work that was done on COVID vaccination development using RNA technology to rapidly produce some effective Mpox vaccines. What about transmission routes? Thinking more about infection prevention control and measures we might take to prevent spread, particularly in our hospitals. So transmission routes for Mpox are recognised as contact with skin and mucous membranes or through the air. I'm using the latest WHO terminology there, what would have previously considered airborne droplet spread. So there's a bit more information that we can talk about there if people would like to. Mpox does not spread easily between people unless there's very close contact. Close contact spread is predominantly through direct contact with scabs or lesions, including during sexual contact or non-sexual contact. Coughing is known to have spread Mpox previously, and contact with contaminated materials, particularly bedding and towels, has also been implicated in transmission. We know that zoonotic transmission can occur as well, so contact with an infected animal can also result in the acquisition of and the transmission of Mpox. I picked up this useful systematic review of studies looking at transmission routes of Mpox. I don't think this is definitive, but I found it quite useful in terms of trying to understand hierarchy, if you like, of transmission of Mpox. So this looked at all of the cases of Mpox where the transmission route has been studied as definitively as possible. So of the 4,000 cases where they felt there was a direct assessment of route of transmission, they found that over half, 55%, were through direct sexual physical contact, and a much, much smaller proportion via non-sexual physical contact, fomite transmission, transplacental, through sharps or inhalation. And they found that multiple routes were common, around 25% of cases, and around 25% were unknown. So I think that analysis was helpful for me to really shine a light on the sexual and direct physical contact of Mpox. And this is across clades. This isn't looking at one clade in particular. So how do we measure the transmissibility, if you like, of Mpox and compare that with other viruses? Well, we can use a couple of measures of transmissibility. One is R0, so that's the average number of cases in an infectious disease that will arise from a single infected individual in a population that's not previously encountered that disease. And the secondary attack rate is similar, but it's the probability that infection will occur among susceptible people within a specific population. So we often talk about, for example, the household secondary attack rate. So looking at the R0 of Mpox, we know that clade 1, the early outbreaks was less than 1, and we can actually see that in the way that it spread, or rather didn't spread in Africa. It was restricted to small localized outbreaks. Clade 2b, something changed in the viral makeup, and that allowed it to spread better. And we see an R0 estimated to be between 1.5 and 3.5 for the clade 2. If we contrast that with something like measles or chickenpox, we can see the estimates of R0 are an awful lot higher for those viruses, meaning they are more transmissible. Similarly, with data around secondary attack rate, looking at Mpox clades combined, people talk in terms of around 0 to 10%. So even in a household with the kind of normal household contact between family members, you'd only expect up to 10% of household contacts to become contaminated to become infected with Mpox rather. The secondary attack rate for sexual contact would be higher. Measles, again, it's over 50%, as is chickenpox. Again, just for the purposes of comparison, this is a nice systematic review and meta-analysis of the secondary attack rate for SARS-CoV-2, so COVID, in a household setting. And you can see how this rose from something like 20% for the initial beta variant up to more than 40% for Omicron. So that falls between the Mpox virus and measles and chickenpox in terms of transmissibility. Moving on to think about environment and surface survival, we don't have any data, as far as I know, on the surface survival of the Mpox virus itself, but there is quite a lot of data around surface survival of vaccinia virus, which is a closely related virus from the same viral family that is likely to share the same environmental properties as Mpox, and it's used as a surrogate for things like disinfectant testing. So we can see vaccinia virus does survive really quite well on surfaces over a 28-day range at room temperature. On most materials, you were seeing a significant chunk of virus surviving, albeit with a fairly large log reduction. Temperature didn't seem to make a huge difference on stability. When we think about disinfectant susceptibility, you can see envelope viruses there at the bottom of that green pyramid, or the green segment of the pyramid, as the least resistant to chemical biocides. So that means that it's good news in that all of the routinely used hospital biocides, be it for hands or surfaces, are going to be effective against Mpox virus. That includes alcohol, gel, sodium hypochlorite, hydrogen peroxide, paracetic, hypochlorous acid, the usual sorts of things that we use, quats as well. So we don't have any issues in terms of efficacy against this virus. What about environmental contamination practice? Well, I think the short answer is we see a lot of it. When you start swabbing the environment for environmental contamination with Mpox, it's there more often than it is not there. This was a study in 2 hospital rooms in Germany. Mpox viral DNA was detected on 36 different surfaces across these 2 rooms and was cultured from 3 of them as well. The figure on the right gives you a measure of the intensity of contamination on the various sites in the room, and you can see quite high intensity contamination in the bathroom and unsurprisingly lower intensity contamination in the entry area, the ante-room, where PPE would have been taken on and off, but still some evidence of contamination there. Another study published in 2022 looked at contamination of 5 patient rooms and in 3 doffing areas and some air sampling as well. A really high proportion of these samples were positive for Mpox viral DNA. So 93% of the 60 samples that were collected. Now, detecting DNA on the surface is not the same as detecting a viable virus on the surface. They did find that 2 of the 4 samples they tested, they could culture virus from them. The figure on the right shows the results from the PPE doffing area, and you can see the surface of PPE was contaminated. For the gloves and the gown, they also found an air sample positive in the doffing area as well. So it certainly supports this idea of fairly widespread contamination of the environment. It's likely to do with shedding from the skin, which is why we're seeing this contamination throughout the clinical environment. In terms of patient testing, viral swabs should ideally be collected from vesicles by rubbing the swab over the lesion. And if there's any pharyngeal lesions, those should be swabbed too with throat swabs. If there aren't any lesions present, then you can take a swab from the throat. However, a negative throat swab doesn't rule out Mpox in that situation. So it's more used as a rule-in for early infection in contacts of cases. Lab testing is via PCR, either locally if you have the facility or via UKHSA. So on to IPC precautions then for Mpox. So I think the headline really is that it depends on the clade that we're talking about. So here in the UK, and slight apologies to any international guests today, I know there are a few. We're going to be talking mainly about the recommendations in England and more broadly in the UK for most of them. I hope that the principles we talk about will be relevant wherever you happen to be working today. So in the UK, Mpox is divided into HSID Mpox, which is clade 1 or cases imported from Africa, and non-HSID Mpox, which is clade 2. And you can see on the right-hand side of the list of airborne high consequence infectious diseases, Mpox clade 1 appears. So how do we determine whether we're faced with a clade 1 or a clade 2 case, an HSID or a non-HSID case? Well, that depends on the case definition. This is the latest UKHSA operational case definition for HSID Mpox. So this would be a patient with clinically suspected Mpox, but the clade unknown, and there is travel history to actually quite a narrow part of Africa. It's DRC plus a relatively small number of countries around it, or there's direct epidemiological links to a clade 1 case. So if either of those are true, then it's a suspected HSID Mpox. However, the case definition for non-HSID Mpox is quite a bit broader, with possible cases described in the left-hand column there, and probable cases on the right. So a possible case is anyone with a fever and known contact with a confirmed case, or a clinical suspicion with lesions as described. A probable case is a slightly broader definition again. So anyone with symptoms, relevant symptoms, who has a contact with a confirmed case, identifies as gay, bisexual, or another man who has sex with men, or has had 1 or more new sexual partners in the 21 days before symptom onset. So the management of those 2 groups, the HSID or the non-HSID Mpox, is different. What I've tried to do here is put down the list of core precautions that we would do for all Mpox cases, regardless of the clade. So hand hygiene using soap and water if your hands are soiled, or an alcohol-based hand hygiene product. Environmental hygiene is clearly going to be important based on the environmental shedding data we looked at. Both cleaning and disinfection is required. Since the monkeypox virus is an envelope virus, we don't need to worry too much about which disinfectant we use. So be it a quat, chlorine, peracetic acid, hydrogen peroxide, etc., will all be effective. There's some specific guidance on contact tracing, which I won't go into today. That may or may not be required depending on the scenario. An airborne isolation room is highly preferable. That may not be possible in all cases, particularly in an assessment setting. But when we have a confirmed case, that's highly preferable. And the waste is the usual waste stream for transmission-based precautions, which is category B. For a non-HSID Mpox, this was a clade 2 Mpox. All Mpox was originally an HSID. There was a recognition that due to the epidemiology of the 2022 outbreak, it didn't make sense for it to remain an HSID. So some Mpox was effectively declassified. So now we can use transmission-based precautions with PPE for possible and probable. UKHSA actually recommended a fluid repellent surgical mask. I think personally, I think I'd be happier with an FFP3 respirator in that setting. Gloves, apron, and eye protection if there's splash or droplet risk, and then a slight upgrade to the PPE if we have a confirmed or highly probable case with an FFP3 respirator, gloves and a gown, and eye protection. Now, if we have a confirmed HSID Mpox case or suspected HSID Mpox case, then we're in the full HSID kit, which is outlined in the National Infection Control Addendum. I would say at this point, though, this is a work in progress, I think, in terms of a guidance point of view. I expect there will be some new guidance forthcoming soon that will create a bit of a middle ground for suspected clade 1 HSID Mpox. I don't think it's very feasible to roll out this kind of PPE right across healthcare if you look at the list and think about the level of training required to do that safely. So I think there's some work to be done on particularly PPE for suspected HSID Mpox. And with that, I'm going to stop because I know that you'll have lots of questions, so please do pop them into the chat, and I will hand back to Phil to lead us through the Q&A.
Thanks very much, John. It was really informative. I certainly learned an awful lot. There's a couple of questions, but I'll start with one of my own if that's all right. I think that's one of the benefits of being chair, isn't it? I was really interested in what you were talking about in terms of environmental contamination and where you're finding the different levels of the virus in the environment. What do you think that means for kind of transmissibility and, thinking about how viruses compare to something like C. diff spores that can hang around in the environment for long periods of time and potentially affect multiple patients? Do we need to worry with viruses? And, is there evidence of transmissibility from, contact with the environment for Mpox?
It's a good question. Lots of unknowns, Phil, really. We don't know a good solid answer to that. I think there's been a lot more data on the organisms that we would consider more traditionally to be linked to environmental spread, norovirus, C. diff, even the antibiotic-resistant bacteria, I think we have more data on. There is a body of evidence around the role of the environment in the transmission of respiratory viruses and other viruses. And there are certain examples and pretty compelling cases where the environment looks to be the only reasonable way in which the virus could have got from A to B. There's no doubt with Mpox, it is shed into the environment. It does survive long enough to be involved in transmission. And for me, that's good enough to mean that we need to be really tight with our environmental hygiene. I suppose for the virus to complete the chain of transmission and get from the surface into a susceptible individual, it would need to make contact with a mucous membrane. So you'd have to have probably hand to mouth, hand to eye. It is a likely route. Looking at the sort of hierarchy of transmission models, I don't think fomite environment spread is going to be particularly up there for Mpox relative to sexual contact and very close physical contact human to human. But in a healthcare setting, particularly, it's certainly not something we can discount.
Yeah, completely understand. Just sticking with the idea of decontamination, and I think maybe this is coming from a community aspect. Liz asks, talking about decontamination of the home environment. So if you've got somebody who has the infection and then keeping their environment in their home safe. Liz goes on to say it was recommended that a property contamination with an external provider was required, which listening to you now, I'm assuming that wouldn't be required. So yeah, any views on decontamination of the home, John?
That's a really good question. And again, it's a bit of an evidence-free zone. There are some recommendations you could say around decontamination of home environments. I can't recall exactly what they said at the moment, but I think a really good thorough clean would be the way to go. I'm not sure that going down the route of external contractors is necessarily commensurate with the risk. If we look at that household secondary attack rate for Mpox, it's not incredibly high.
Thanks, John. I'm just going to stick with the environment and environmental decontamination and then go on to the vaccines and vaccination. I think you alluded to some of the disinfectants that are effective against Mpox, but somebody's asking specifically whether or not chlorine would be sufficient to decontaminate in a hospital setting.
So chlorine would absolutely knock Mpox on the head, no problems at all. Enterovirus against chlorine, really at any concentration is not a fair match. The chlorine is going to win every time. However, there's a big caveat to that because chlorine only works if there's chlorine in the solution. And what we see in a healthcare setting is that chlorine is quite susceptible to break down with, or when it comes into contact with organic matter. So I think being careful that we have a cleaning process in conjunction with that chlorine and looking at other options as well, the other disinfection options in hospital, so we get the optimal choice for us is definitely the way to go.
Thanks, John. If we move on to vaccination then, John, a couple of people have asked about who is eligible for vaccines, in particular sex workers. So do you have information on who is eligible for an Mpox vaccine or a smallpox vaccine?
Not in the top of my head, but I can point you in the right direction. So the National Vaccine Committee has issued recommendations around eligibility for vaccination. I'll pop it into the chat after the call, so it's there for people to look at.
Perfect.
I'll just write that down so I don't forget.
Yeah, I'll remind you. Just building on that, and you talked about the use of the smallpox vaccine. Somebody asked, is there any data available on smallpox vaccination efficacy? Is it effective against infection or does it protect against severe disease? I don't know if you can answer that one.
Yeah, so there's some data on it. It's not with clade 1b Mpox because the data just isn't there yet. It's mainly to do with the 2022 clade 2b. But assuming that we accept the read across between 2b and 1b in terms of clade, which is likely, it's probably in the 80% bracket, so it's pretty good.
Thanks, John. There seems to be a lot of conversation in the chat about the waste categories.
Yeah.
So people asking whether or not it's category A or B, and I think you referred to it being category B in the talk, but
yeah.
Some people saying it's category A.
Okay, so I looked at this carefully today because I found myself in a bit of a loop. I think it might depend slightly which guidance you look at, and there may be a need for clarification of guidance. So HCID category, well, HCID waste is category A. That's the standard for an HCID centre. But there's some guidance from UKHSA that says that all Mpox, regardless of clade, the waste to consider Cat B, even for HCID Mpox. So again, I'll put them in the chat. Have I managed to get through this without saying monkeypox until now?
I wasn't checking, but I think you've used Mpox right.
It's really hard when they change the name all the time. Yeah. Good. Waste. I'm gonna put that in the chat later. The link about waste.
People are commenting and saying only once, and I don't know if that was just now, as in 20 seconds ago.
But hang on, that might have been right at the start when it was still called monkeypox, referring to 1958. So I'm allowed to do that.
Fair, yeah, that's fair. That's fair. We'll let you off. This is a really good question. It's just jumped. Faith, is there any advice with regards to travel to areas? I'm assuming by areas they mean ones that are currently like the DRC. Is there any restrictions and/or vaccination requirements for those countries?
Um, there's government advice on the government travel website. I forget the name, but again, we can put that in the chat. I'm not sure what the current advice is. If I had a holiday booked to DRC, I'd be cancelling it. That would be my own personal advice. But clearly, people will need to go there for professional reasons, and I'm sure there are ways to do that. You know, this is not a massively transmissible virus. You've got to be usually close physical contact, usually sexual contact is the way to spread it. So I think we can be quite proportionate in terms of risk management. I don't think there's been a single incident with the 2022 where a healthcare worker acquired clade 2 monkeypox during their care of patients. So it's a different scenario to previous HSID situations and even respiratory virus situations.
Okay, that's really helpful. I think you might have already started to answer this, but it's still a really good question. It's asking whether or not there might be any guidance of management of healthcare staff who've travelled to affected areas like DRC.
Good question. So I think there probably wouldn't be any special requirements for healthcare staff who've travelled unless they tick one of the boxes that makes them fit the case definition, which would be epidemiological contact with a confirmed case. Yeah, or symptoms and travel symptoms and travel combined. So I think they'd be okay to go about their normal duties. Obviously, be aware and vigilant for the onset of fever or early symptoms of Mpox, and have a very low threshold for staying away from work and being tested. I don't know whether that's the guidance on that point, but that's where I'd be at with that question.
Okay, thanks, John. We've still got a couple more minutes for any more questions, if people want to pop them into the Q&A. Just one more from me, John, as it slipped my mind. Oh, it has. I had one for you and it's completely disappeared. There's another one here in the Q&A now anyway. This one asks, keep jumping around, have UK universities been given advice for students joining them for the new term? That's an interesting one.
I think that probably would relate to the question of healthcare workers. I think unless they meet the criteria for being a case, then there's probably not much required other than vigilance and education of early presentation of symptoms.
Okay, that's helpful. Thank you. My question has come back to me, John. You gave a really good list of all the requirements and the PPE requirements and all the different things that you can bundle together to react if there's a monkeypox case and the requirements. I just wanted to maybe ask you about your own personal situation within Guy's and St Thomas's. Is there anything in particular that you are prioritizing, that if you have cases, that how you're going to deal with them? Or is it just being able to apply that bundle of different measures and interventions if necessary?
So I think a couple of things. One, from my very own personal experience, I'm going to say this lightly. I've had a go with HSID PPE. I've never used it in anger, and that big ensemble is really hard, really hard to put on. It's a lot of steps involved. There's a lot of layers, and for me, every layer of PPE you're putting on is a layer of risk. If we remember the contamination rates at the outside of the PPE. So whilst for a confirmed HSID, obviously the HSID ensemble makes complete sense. I think in an assessment situation where, yes, you have a risk of HSID, clade 1 monkeypox, Mpox, there you go. We need to take care of our healthcare staff. I think putting them in too much PPE, just as a point of principle that we learned from COVID, isn't necessarily the safest thing. So I think if we look at the key points of transmission, it would be protecting the respiratory tract, protecting your eyes, and making sure that we've got good hand hygiene and preventing the contamination of our clothes. And unless there's serious body fluid exposure risk, I think I can see a kind of intermediate step between the full HSID ensemble and what might be safe on the front line.
Great, that's really helpful. I think you answered a lot of the questions then around PPE as well. Just one to close then, John, and maybe a bit of a trying to look into the future. And I know you don't have a crystal ball, but what do you think is next when it comes to Mpox? Do you think we are needing more guidance? Do you think that we're going to see an influx in cases? Where do you think we stand in the next 3 months?
Oh, now that is a difficult question. Yeah, we do need more guidance. I think the guidance that is out there in England in particular is written mainly for the clade 2b Mpox, and the clade 1b is different in terms of its epidemiological presentation, in terms of the risk factors. So I hope there will be some more, particularly PPE guidance forthcoming. In terms of prevalence and community risk, I don't see this being a big issue in terms of in-country spread within England or within the UK, or really outside of Africa. I think it's likely to be some imported cases with a little bit of localized outbreak management. But I think we do all need to be prepared for that case that turns up in the ED or the sexual health clinic, and make sure that we've got good, strong messages out to frontline teams to make sure that they're as safe as can be.
Great. Thanks, John. That's really helpful. One more, because I think it's a quick one. In a healthcare setting, does a suspected or positive case need to be isolated in a negative pressure room?
If you got one, absolutely. And I think it would probably depend on the kind of index of suspicion. If you have a symptomatic case that looks like Mpox, they've just come back from DRC, then yeah, I think we need to be prioritizing a negative pressure isolation room in that scenario. I think if it's a lower level of suspicion with less concerning risk factors, then if you don't have a negative pressure room, then a single room without negative pressure would be okay.
Great. Okay. Great talk, John. Really informative and great engagement from the audience. And we had at one point 279 people online. So thank you all for attending, and thank you for your time, and lots of positive comments in the chat. So just finally, one more big thank you to John, and a really informative talk. In terms of what's next for IPC partners and our journal clubs, there's links there where you can see the full schedule for our journal clubs. As John and I said before, we're trying to keep a frequency of 2 weeks, and we are really open to people coming on and being guests if they want to review a particular paper or something of interest. So please get in touch with us. Our email address is there, or you can reach out to us on social media channels such as X or LinkedIn. You can also subscribe, so there's a mailing list. You won't be spammed. It will just give you the updates about when we are scheduling our next journal clubs. So we'd love you to sign up and subscribe to that. And again, if you're interested on coming on board and being a guest, then we don't bite, and we'd love to hear from you. So just a final thank you for John, and we'll see you hopefully on the next IPC Partners Journal Club. Cheers, John. Thanks, everybody.
Thanks, Phil. Thanks for carrying everyone. Bye.